Welcome all for the today's session. So we continue with our recall and revise series, and this series is going to be very important from the examination point of view, which is hardly 15 days ahead now. Dr. Sansi, can you please read the question? Today we will cover the anatomy module. Okay.
Yes, sir. A 28-year-old woman undergoes a fenestrial incision during a LSCS. During closure, the trainee is advised to avoid injury to the iliohypogastric and ilioinguinal nerve running near the lower abdominal wall. The iliohypogastric and ilioinguinal nerves arises from which of the following spinal nerve roots? T12, L1, 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 L2, L2, L3, T12, L2. Sir, L1, option B, L1.
Yes, very frequently asked this particular question. They may twist the question, ask in a different way, but iliohypogastric, ilioinguinal nerves are very much frequently asked, and you should remember these nerve roots. It's from L1. Okay, so the iliohypogastric, ilioinguinal nerves are branches of the lumbar plexus and primarily arise from L1 nerve root. Both nerves emerge from the lateral border of the psoas major muscle. They course across the quadratus lumborum. The nerves are commonly at risk during one fenestrial incision, inguinal surgery, cesarean section, lower abdominal wall procedure. So the question may be framed from this also, but the answer will be same. Then iliohypogastric nerve supplies suprapubic skin, motor supply to the internal oblique and transversus abdominis muscle. Ilioinguinal nerve passes through the inguinal canal, supplies upper middle thigh and genital region. Okay, so in examination, iliohypogastric and ilioinguinal nerves are classically tested together, and both are derived mainly from L1. Okay, so sometimes
Yes,
they can give the figure also along with it. Okay, the figure is not getting loaded, but it may be an image based question also. Next question, doctor.
during pelvic dissection in a gynecological oncology procedure, a trainee is asked about the structures passing through the lesser sciatic foramen. Which of the following structure exits the pelvis through the lesser sciatic foramen? Piriformis muscle, sciatic nerve, obturator internus tendon, superior gluteal vessels, femoral nerve. Yes, sir. Option D, superior gluteal vessels.
No,
Superior
through the lesser sciatic foramen. The only structure which passes through the lesser sciatic foramina is an
internus tendon.
obturator internus tendons. Oh, okay, the obturator internus tendon exits the pelvis through the lesser sciatic foramina before inserting onto the greater trochanter of the femur. Lesser sciatic foramina transmit tendon of obturator internus, pudendal nerve, internal pudendal vessels now to the obturator internus. Okay, so this question may be from frame from this also. Okay, that is why I am covering the explanation also. Okay, so important anatomical correlations are piriformis muscle passes through the greater sciatic foramina. Remember, piriformis muscle, greater sciatic foramina. Sciatic nerve also exit via greater sciatic foramina. Superior gluteal vessels pass above the piriformis through the greater sciatic foramina, and femoral nerve passes beneath the inguinal ligament. Okay, so these are important relations you are supposed to know. Obturator internus tendon exits the pelvis through the lesser sciatic foramina. This is an important landmark in the pelvic anatomy and surgical anatomy. Next question, doctor.
Yes, sir. A fetus undergoes normal circulation in utero through several vascular shunts that help bypass the lungs and the liver. The ductus venosus connects which of the following structure? Umbilical vein to inferior vena cava, umbilical artery to inferior vena cava, pulmonary artery to aorta, right atrium to left atrium, portal vein to hepatic artery. Sir, option A, umbilical vein to inferior vena cava.
Correct. So this ductus venosus is an important fetal vascular shunt that connects the umbilical vein to the inferior vena cava. This allows oxygenated blood from the placenta to bypass the fetal liver and reach the heart rapidly. Okay, so the shunts, these shunts we have taken in detail, and please go through our lecture on this fetal circulation. Okay, so ductus venosus will connect the umbilical vein to the IVC. Foramina ovale is between the right atrium and the left atrium. Then ductus arteriosus from the pulmonary artery to the aorta. Okay, so ductus venosus allows preferential streaming of the oxygenated placental blood to the fetal heart and brain. After birth, the ductus venosus closes and forms the ligamentum venosum. This is also SVA. Doppler assessment of the ductus venosus is important in fetal medicine and aneuploidy screening. Okay, so during radical, next question is here. This is the next question.
Yes, sir. During a okay. During a radical hysterectomy, the surgeon identifies the internal iliac artery. During a radical hysterectomy, the surgeon identifies internal iliac artery. Okay, while tracing the course of the ureter in the pelvis, which structure lies lateral to the internal iliac artery. Ureter, external iliac vein, uterine artery, obturator nerve, sigmoid colon. Sir, option E, ureter. Yes, sir. A 32-year-old woman undergoes laparoscopic surgery for endometriosis. During insertion of a suprapubic trocar below the umbilicus, the surgeon discusses the sensory nerve supply of the infraumbilical anterior abdominal wall, which nerve provides sensory innervation to the skin below the umbilicus. Subcostal nerve, iliohypogastric nerve, genitofemoral nerve, pudendal nerve, lateral femoral cutaneous nerve. The iliohypogastric nerve, option B.
Yeah, because we are talking about below the umbilicus. It is iliohypogastric. The iliohypogastric nerve arises from L1 spinal nerve and supplies the skin of the lower anterior abdominal wall below the umbilicus. So origin is L1 nerve root, branch of lumbar plexus, supplies internal oblique muscle, transversus abdominis muscle, and suprapubic skin and lower abdominal wall. This also we have seen just now. The iliohypogastric nerve may be injured during financial incision, caesarean section, laparoscopic port insertion, and hernia surgery. Skin around the umbilicus, T10 dermatome. Skin below the umbilicus, suprapubic region, predominantly iliohypogastric, that is L1. Okay, so skin around the umbilicus can be another as be a T10. Below the umbilicus, suprapubic region is L1. Okay, predominantly hypogastric. Okay, other options why they are not correct. Subcostal nerve supplies the upper abdominal wall, that is T12. Genitofemoral nerve supplies the upper anterior thigh and the genital region. Pudendal supplies the perineum, and lateral cutaneous nerve or the lateral femoral cutaneous nerve supplies the lateral thigh. Okay, so please see what exactly the question is asked, because the question may be skin over the umbilicus, or the question may be pelvic viscera below the pelvic brim. Okay, if they ask you the pelvic viscera below the pelvic brim, then answer will be inferior hypogastric plexus. If they ask the skin below the umbilicus, it will be iliohypogastric nerve. Okay, so if it is an internal viscera, it is going to be inferior hypogastric plexus. If it is the skin, it will be iliohypogastric nerve. Okay, next question,
Yes, sir.
doctor.
A 60-year-old woman undergoes radical pelvic surgery for cervical carcinoma. Okay. Radical pelvic surgery for cervical carcinoma. During the procedure, autonomic nerve fibers supplying the urinary bladder are identified and preserved to reduce the post-operative bladder dysfunction. The sympathetic innervation of the urinary bladder arises from which of the following spinal cord? S2, S3, S4, T10 to L2, L4 to S1, S1 to S3, T6 to T9. Sir, option A, S2 to S4.
Yes, in the the sympathetic innervation of the bladder, it is a sympathetic they are asking. Please concentrate what is the question which has been asked. Okay, the sympathetic innervation of the bladder originates from the thoracolumbar spinal nerves, the segments from T10 to L2. The fibers will travel through the lumbar splanchnic nerve, superior hypogastric plexus, hypogastric nerves, and inferior hypogastric plexus. The function of the sympathetic innervation is relaxation of the detrusal muscle, contraction of the internal urethral sphincter, and promotes the urine storage phase. While now your answer comes when we are discussing about the parasympathetic innervation. Okay, it arises from S2 to S4 pelvic splanchnic nerves, causes detrusal contraction and bladder emptying. So now these small mistakes we should not commit. Okay, so sympathetic is from T10 to L2, that is the related to the storage of the urine, while parasympathetic is S2 to S4 related to the voiding of the urine. Okay, so S2 to S4 is a parasympathetic supply, L4 S1 is not a primary bladder autonomic supply, S1 to S3 is an incomplete or incorrect parasympathetic origin, and T6 to T9 sympathetic supply to the upper abdominal viscera. Next, this is again little difficult type of question. Let me see if I can. Yeah, you can start answering, doctor. Read
Okay,
the
sir.
question.
A 35-year-old woman sustains pudendal nerve injury during a complicated instrumental vaginal delivery. Pudendal nerve injury. Okay. During a complicated instrumental vaginal delivery, the consultant discusses the sensory and motor function supplied with the pudendal nerve. Which of the following combinations correctly describes the function of pudendal nerve? Okay. Pudendal nerve. Option A, options are sensory supply to the upper one third, then sensory supply to the lower canal, then motor supply to the external, then motor supply to the intra-anal sphincter, and sensory supply to the perianal skin. So it supplies the lower anal canal, and
we are talking about pudendal nerve. Pudendal nerve will be related to the pelvic viscera. Okay, so now pelvic viscera, what hint you are getting from the options which are available? Okay, think logically at least. When the question is complicated, not try to get more and more hints from the question itself. Is it going to be sensory? Is it going to be the motor, or both? And which part?
Both. Pudendal nerve supplies the both. So it is going to supply the lower anal canal and the perianal skin. So the option B and E, out of option B and E, we have to. But it supplies the internal. So the option E, internal anal sphincter, lower anal canal, and perianal skin.
B and E are most similar, but still okay. So answer is B. The pudendal nerve S2 to S4 is the principal somatic nerve of the perineum. It is a sensory supply to the lower one third of the anal canal, perianal skin, and vulva and lower vagina. So lower anal canal below the pectinate line. This also we have gone into detail what exactly the pectinate line is and all. Motor supply to the external anal sphincter, external urethral sphincter, and perineal muscles. Okay, pudendal nerve does not supply upper anal canal. It is a visceral or autonomic innervation. Remember, anal canal upper part, visceral or autonomic. Internal anal sphincter, smooth muscle under autonomic control. Okay. So important anatomical correlations. Upper anal canal has got a autonomic from inferior hypogastric plexus. Lower anal canal from the pudendal nerve. External anal sphincter from pudendal nerve. Pudendal nerve. Internal anal sphincter, autonomic sympathetic fibers. Okay. So the pectinate line is an important embryological and neurovascular landmark. The structures below the pectinate line have somatic innervation, pain sensation, and pudendal nerve supply. Okay, very important concept. Okay, pectinate line. Then sutures above the pectinate line will have structures above the pectinate line will have visceral innervation, autonomic supply, and poor pain localization. Okay, so these are the true and false status of the rest of the this sentences which were given. Okay, that is why the option is B. So you may expect such kind of questions in multi-level true false. Okay, these kind of questions, and they are little tricky, and you get stressed out with such question. Okay, so in the examination, keep yourself very cool, think logically. Next, doctor.
During laparoscopic evaluation of chronic pelvic pain, the surgeon identifies a structure entering the deep inguinal ring. The trainee is asked about the structure commonly visualized traversing the deep inguinal ring during laparoscopy in females. Which of the following structure passes through the deep inguinal ring and can be identified laparoscopically? Round ligament passes, broad ligament, ovarian ligament has no relation, suspensory ligament of the ovary. It has no relation. Uterosacral ligament. Sir, option A, round ligament of the uterus.
Correct. Round ligament of the uterus passes through the deep inguinal ring, traverses in the inguinal canal, and ends in the labia majora. It is commonly visualized during the laparoscopy as it courses from the uterine cornea upwards towards the lateral pelvic wall and enters the deep inguinal ring. Okay, so important anatomical pathway: uterine cornea to the deep inguinal ring to the inguinal canal, then superficial inguinal ring, then it will get inserted into the labia major. Okay, so embryological correlation: the round ligament is the female homologue of gubernaculum testis. This is also SBA. Okay, the deep inguinal ring lies lateral to the inferior epigastric vessels. Deep inguinal ring lies lateral to the inferior epigastric vessels. Indirect inguinal hernia pass through the deep inguinal ring. During laparoscopic, the round ligament is an important landmark for identifying the pelvic sidewall anatomy. Okay, So why other organs options are incorrect? Broad ligament is peritoneal fold and does not traverse the inguinal canal. Ovarian ligament, same, it won't travel through the inguinal canal. Then suspensor ligament of the ovary carries the ovarian vessels to the lateral pelvic wall, and uterosacral ligament again has nothing to do with this inguinal canal. Next, doctor.
During a radical hysterectomy, the surgeon identifies a fibrous condensation extending from the lateral aspect of the cervix to the pelvic side wall and the endopelvic fascia. Preservation of adjacent structure is important to avoid the ureteric injury. So, from the lateral aspect of the cervix to the pelvic side wall. So, we are talking about cardinal ligament, which ligament arises from the lateral border of the cervix and is attached to the endopelvic fascia. Broad ligament, round ligament, cardinal ligament, uterosacral ligament, ovarian ligament. Sir, the option is C, cardinal ligament.
Correct. Cardinal ligament. The cardinal ligament, also called as transverse cervical ligament or McEnroe's ligament, extends from the lateral aspect of the cervix and upper vagina to pelvic side wall or endopelvic fascia. It is one of the major supports of the uterus and cervix. Important anatomical correlations: it contains the uterine artery, uterine vein, lymphatics. Closely related to the ureter, water under the bridge relationship is there. Ureter passes beneath the uterine artery within this region. Functions: provides apical uterine support, prevents uterine prolapse, important surgical landmark in the pelvic surgery. So cardinal ligament will attach cervix to the pelvic side wall or the endopelvic fascia. Uterosacral ligament, cervix to the sacrum. Round ligament, uterus to the labia majora via the inguinal canal. And broad ligament, it is a peritoneal fold supporting the uterus. Okay. So why other options are incorrect? Broad ligament is the double fold of peritoneum. Round ligament passes through the inguinal canal. Uterosacral ligament extends from posterior toward the sacrum, and ovarian ligament connects the ovary to the uterus. Okay. Next, doctor.
During laparoscopic pelvic surgery, the surgeon identifies the ovarian vessels arising directly from the abdominal aorta. Okay. While tracing the infundibulopelvic ligament, at which vertebral level does the ovarian artery usually arises from the abdominal aorta? T10, T12, L1, L2, L4. So option A, T10.
L2. We are talking about the ovarian vessels. It is an L2. The ovarian arteries are paired vessels arising directly from the abdominal aorta at the level of the L2, just inferior to the renal arteries. Okay, it is a lumbar vertebra. Okay, then arises from the abdominal aorta at L2, descends retroperitoneally, crosses anterior to the ureter, travels within the infundibulopelvic ligament, that is the suspensor ligament of the ovary, supplies ovary and contributes to the uterine blood supply. So important surgical relevance: the ovarian vessels are important during oophorectomy, salping oophorectomy, pelvic lymphadenectomy, surgery for adnexal masses. Important from examination point of view: vertebral level and the vessels. These are all SBs. You can take the screenshot of this. Celiac trunk, T12. Okay, superior mesenteric artery, L1. Renal arteries, L1, L2. Ovarian arteries, L2. Inferior mesenteric artery, L3. Aortic bifurcation at L4. Any of these can be asked in the examination. Okay. So at T10, esophageal hiatus level is the T10. Okay. T12 is the celiac trunk origin. This is also SBA which has been frequently asked. Okay. L1, superior mesenteric artery origin. This is also asked. L4 is the aortic. All three have been asked. Okay. Next. Very important.
Yes. During pelvic lymphadenectomy, the surgeon identifies the bifurcation of abdominal aorta into the common iliac arteries while tracing the pelvic vessels. At which vertebral level does the abdominal aorta bifurcates into the common iliac artery? So it is L4, option D.
So aortic bifurcation into two common iliac arteries is at L4. The abdominal aorta bifurcates into the right and left common iliac arteries at the level of the fourth lumbar vertebra. Important anatomical: the bifurcation usually occurs slightly left to the midline. The common iliac arteries then divide into external iliac artery and the internal iliac artery. Knowledge of the aortic bifurcation is important during pelvic surgery, para-aortic lymphadenectomy, vascular procedures, and identification of the pelvic vessels during laparoscopy. Celiac trunk, T12, supramesenteric artery, L1, renal arteries, L1, L2, ovarian arteries, L2, inferior mesenteric artery is L3, and aortic bifurcation L4. Okay, so this is all we have seen. Next.
Okay. During laparoscopic salpingo-oophorectomy, the surgeon ligates the ovarian vessels within the inferior IP ligament. The trainees ask about the origin of the gonadal artery. The gonadal artery is a direct branch of which of the following vessels? Common iliac artery, internal iliac artery, renal artery, abdominal aorta, inferior mesenteric artery. Sir, option D, abdominal aorta.
Yes. So the gonadal arteries, that is the ovarian vessels in females, and the testicular arteries in males, arise directly from the abdominal aorta. Abdominal aorta at approximately L2 level arise just inferior to the renal arteries, descend retroperitoneally in females. The ovarian artery travels within the suspensor ligament of the ovary or the infundibulopelvic ligament. The ovarian artery supplies ovary, fallopian tube, and anastomotic branches to the uterus. Okay. Surgical relevance is that ovarian vessels are important during oophorectomy, pelvic sidewall surgery, adnexal surgery, management of ovarian torsion. And ovarian gonadal artery origin is from abdominal aorta. Uterine artery is a branch of internal iliac artery. Ovarian artery level is L2. Okay. Why other options are incorrect? Common iliac artery divides into external and internal iliac artery. Internal iliac artery gives uterine artery and vaginal artery. Renal artery supplies kidneys. Inferior mesenteric artery supplies the hindgut. Okay, next.
During examination of the external genitalia in the gynecological clinic, a trainee is asked to identify the anatomical boundaries of the vaginal vestibule. The vestibule of the vagina lies between which of the following structure? Labia majora, clitoris and the focket, istiopubic rami, labia minora, and bulbs of the vestibule. Sir, option B, clitoris and the focket.
No. We are talking about vestibule of the vagina. It is between the labia minora. Okay. The vestibule of the vagina is a space enclosed between the labia minora. It consists of the opening of the urethra, vagina, and Bartholin glands duct. Okay. So boundaries of the vestibule are laterally you have labia minora, anteriorly you have clitoris, and posteriorly you have foresheet. Okay. So actually all these three are forming the boundaries of the. So your answer is not absolutely wrong, but the expected was labia minor. The labia majora lies lateral to the labia minora. The bulb of the vestibule are erectile tissues deep to the labia. Bartholin glands are situated posterolaterally in the vestibule. Vestibule is the space between the labia minora. Urethral opening lies anterior to the vaginal opening, and Bartholin gland ducts open into the posterior vestibule. Okay. So why other options are incorrect? Labia majora form the outer boundary of the vulva and not of the vestibule. Then clitoris and foresheet are anterior and posterior landmarks only. Okay. Istiopubic rami form the bony pelvic boundaries, and bulb of the vestibule are the deep erectile structures. Next.
During vulval surgery, the surgeon takes care to preserve the sensory innervation of the clitoris to maintain post-operative sexual function. Takes care of the sensory innervation of the clitoris to maintain the post-operative sexual function. The dorsal nerve of the clitoris is a branch of which of the following nerves? Ilioinguinal nerve, genitofemoral nerve, pudendal nerve, pelvic splanchnic nerve, inferior hypogastric plexus. Sir, option C, pudendal nerve.
So pudendal nerve, the dorsal nerve of the clitoris is the terminal branch of the pudendal nerve, that is S2 to S4. Sensory innervation to the clitoris, important role in sexual sensation. Course is pudendal nerve exits pelvis through the greater sciatic foramina, enters the perineum via lesser sciatic foramina, then traverses the pudendal canal, that is Alcock's canal, gives terminal branches including inferior rectal nerve, perineal nerve, and dorsal nerve of clitoris. This is very, SBA can be asked on this. Okay. It exits the pelvis through the greater sciatic foramina, but it will enter the perineum via lesser sciatic foramina. Okay. So pudendal nerve will supply mainly to the perineum and the external genitalia. Dorsal nerve of clitoris, sensory supply to the clitoris, dorsal nerve of clitoris, and pelvic splanchnic nerve that will give the parasympathetic pelvic viscera. Okay. So damage to the dorsal nerve of the clitoris may occur during the vulval surgery, female genital cosmetic procedures, extensive episiotomy repair, and pelvic floor surgery. Okay. So why other options are incorrect? Ilioinguinal nerve supplies the mons pubis and the upper medial thigh. Then genitofemoral nerve supplies upper anterior thigh and the labia majora. Pelvic splanchnic nerve provides parasympathetic pelvic innervation, and inferior hypogastric plexus is an autonomic plexus supplying the pelvic organ. Next.
During laparoscopic port placement near the ASI, a trainee is cautioned about injury to the nerve that passes medial to the anterior superior iliac spine and causes post-operative meralgia paresthetica, which nerve passes medial to the ASI, femoral nerve, obturator nerve, genitofemoral nerve, lateral femoral cutaneous nerve, iliohypogastric nerve. Sir, option D, lateral femoral cutaneous nerve.
Yeah, lateral cutaneous nerve of the thigh or lateral femoral cutaneous nerve of the thigh. The lateral femoral cutaneous nerve, that is L2 to L3, passes medial to the ascis and beneath the inguinal ligament before entering the thigh. It provides sensory innervation to the lateral aspect of the thigh. Compression or injury to this nerve causes meralgia paresthetica, burning pain, numbness, tingling over the lateral thigh. So common causes are the tight clothing, obesity, pregnancy, pelvic surgery, trocar placement near ascis. Okay. So now lateral femoral cutaneous nerve passes medial to the ascis. Femoral nerve passes beneath the inguinal ligament, lateral to the femoral artery. Again, relationship is very important. Femoral artery, femoral nerve, vein, etc. Then obturator nerve passes through the obturator canal. Why other options are incorrect? Femoral nerve lies deeper in the femoral triangle. Obturator nerve enters medial thigh through the obturator canal. Genitofemoral nerve runs on the psoas major and iliohypogastric nerve supplies the lower abdominal wall. Next.
During an anatomy teaching session, a trainee is asked about the arterial supply of the embryological midgut and its origin from the abdominal aorta. The vessel supplying the majority of the midgut branches from the abdominal aorta at which vertebral level? T10, T12, L1, L3, L4. Sir, option C, L1.
And which vessel supplies the midgut?
Superior mesenteric artery.
Yes, L1. The superior mesenteric artery SMA supplies the majority of the midgut and arises from the abdominal aorta at the level of the L1. The structures which are supplied by the midgut vessel are the distal duodenum, jejunum, ileum, cecum, appendix, ascending colon, and proximal two-thirds of the transverse colon. Okay, so foregut arterial supply is celiac trunk, vertebral level T12, midgut superior mesenteric artery L1, hindgut inferior mesenteric artery L3. Okay, all three SBH. So SMA arises just inferior to the celiac trunk. Then the Ovarian arteries arise slightly below the SMA around L2. Then knowledge of the embryological blood supply is frequently tested in your examination, and T10 is esophageal hiatus level is the T10. Celiac trunk origin is T12. Inferior mesenteric artery origin is L3 and aortic bifurcation L4. Okay, next.
Yes. During an anatomy viva, trainee is asked about the arterial supply of the embryological hindgut and its origin from the abdominal aorta. The vessel supplying the hindgut branches from the abdominal aorta at which vertebral level? Sir, option D, L3 level.
Yes, just now we have seen the inferior mesenteric artery IMA supplies the hindgut and arises from the abdominal aorta at the level of the L3. Structure supplied by the hindgut, distal one-third of the transverse colon, descending colon, sigmoid colon, the rectum. So foregut celiac trunk T12. This all we have seen. Inferior mesenteric artery arises inferior to the ovarian arteries. Superior rectal artery is the terminal branch of inferior mesenteric artery. Superior rectal artery is the terminal branch of inferior mesenteric artery. Hindgut derivatives are commonly tested in your examination, and this all we have seen all levels. Next.
Okay. So I can see the option questions.
This is the question in the middle.
Yes. I can see. During colorectal surgery teaching, a trainee is asked about the principal arterial supply of the transverse colon. Principal arterial supply of the transverse colon. Which artery provides the main blood supply to the majority of the transverse colon? Inferior mesenteric artery, iliac artery, middle colic artery, left colic artery, superior rectal artery. The middle colic artery.
No. So transverse colon, no, just now we have seen transverse colon, two-third and one-third we have seen, no, just now. No, middle colic artery. Yeah, the middle colic artery is a branch of superior mesenteric artery. Okay, so the middle colic, so it will the superior mesenteric through the middle colic artery it will supply, provides the principal blood supply to the majority of the transverse colon, arises from the SMA, travels within the transverse mesocolon, supplies proximal two-third of the transverse colon, contributes to the marginal artery. So proximal 2/3 of the transverse colon is a midgut derivative. Distal 1/3 is a hindgut derivative. Okay. So additional blood supply, the distal transverse colon also receives contribution from left colic artery, that is the branch of inferior mesenteric artery. Okay. So colon segment, ascending colon, right colic artery. Transverse colon, middle colic artery. Descending colon, left colic artery. Sigmoid colon, sigmoid arteries. Okay. So why other options are incorrect? Inferior mesenteric artery mainly supplies the hindgut. Iliacolic artery supplies the cecum and the terminal ileum. Then left colic artery supplies the descending colon and the distal transverse colon, and superior rectal artery supplies the rectum. Next.
A patient undergoes laparoscopic appendectomy for acute appendicitis. During the procedure, the surgeon identifies and ligates the appendicular artery within the mesoappendix. The appendicular artery is most commonly a branch of which of the following arteries? Right colic artery, iliacolic artery, middle colic artery, superior mesenteric artery, inferior mesenteric artery. Sir, option B, iliacolic artery.
Yes, this is also frequently asked. The appendicular artery is usually a branch of iliacolic artery, which itself arises from superior mesenteric artery. Iliacolic artery gives rise to colic branch, iliac branch, anterior and posterior cecal arteries, appendicular artery. The appendicular artery travels within the mesoappendix. The appendicular artery is a end artery. Occlusion will rapidly lead to the ischemia and gangrene of the appendix. So appendix supplies artery, arterial supplies appendicular artery. Appendicular artery origin is iliacolic artery. Iliacolic artery origin is a superior mesenteric artery. Okay. So right colic artery mainly supplies the ascending colon. Middle colic will supply the transverse colon. Superior mesenteric artery is a parent vessel, not direct branch in most cases. Okay. And inferior mesenteric artery will supply the hindgut. Next.
During antenatal teaching on fetal skull anatomy, a trainee is asked about the boundaries of the largest fontanelle of the fetal skull. Okay. Which suture encloses the anterior fontanelle, the largest fontanelle of the fetal skull? Sagittal and lambdoid, coronal and lambdoid, sagittal, coronal and frontal sutures, coronal and squamous suture, or frontal and lambdoid suture. So option C, sagittal, coronal and frontal sutures.
Correct. See, the anterior frontal is the largest frontal of the fetal skull and the diamond shape. It is enclosed by the junction of the sagittal suture, coronal suture, frontal suture. So anterior frontal is a diamond shaped sagittal plus coronal plus frontal. Posterior frontal is a triangular. It is sagittal plus lambdoid. Okay. So clinical relevance, assessment of the frontal is important for the fetal head position during the labor, neonatal examination, assessment of the dehydration and intracranial pressure. Okay. The anterior frontal helps to identify the fetal head attitude during the vaginal examination. A large palpable anterior frontal may indicate deflection. Posterior frontal is a smaller and triangular. Okay, why other options are incorrect? Sagittal and lambdoid sutures that will form the posterior frontal. So coronal and lambdoid sutures, not a frontal boundary combination. Coronal and squamous suture, again incorrect combination. Frontal and lambdoid suture cannot anatomically related. Okay, next.
During labor ward teaching, a registrar discusses the dimension of the female pelvis, okay, and the characteristics of the mid-pelvis. Which of the following statement regarding the diameter of the mid-pelvis is correct? Anterior posterior diameter widest, oblique diameter widest, transverse diameter widest. Mid-pelvis or anterior. All three are equal, so 12 centimeter actually in mid-pelvis.
Yeah. So
Option A.
yeah,
Option
it will be yes, option A, because all are same and all are wide. Okay, in mid pelvis. Okay, at outlet and at inlet it is different. Okay, so the mid pelvis is the roomiest part of the true pelvis, and at this level the anteroposterior, oblique and transverse diameter are all relatively wide. The mid pelvis lies approximately at the level of the ischial spine plane of the least pelvic dimensions. Obstetric importance is that assessment of the mid pelvis is important because the fetal head rotates at this level. Narrowing may lead to deep transverse arrest, obstructed labor. So pelvic level, an important feature. Okay, pelvic inlet transverse diameter is the widest. Mid pelvis all diameters are relatively wide, and outlet AP diameter decreases during the labor. Okay. So clinical correlation, prominent ischial spine indicate reduced interspinous diameter or contracted mid pelvis. This is an important cause of labor distress. Next.
A newborn baby is noted to have congenital absence of the mastoid process. The pediatrician explains that one of the important cranial nerves is more vulnerable to injury because it normally lies unprotected in this region, which structure is more at risk of damage in the absence of the mastoid process. Glossopharyngeal, vagus nerve, facial nerve, hypoglossal nerve, accessory nerve. Sir, option C, facial nerve.
Yes. So the facial nerve, that is the cranial nerve 7, is vulnerable in infants because the mastoid process is poorly developed or absent at birth. Normally, the mastoid process helps to protect the facial nerve after it exits the stylomastoid foramina. Clinical significance: in neonates, facial nerve lies superficially, increased risk of injury during forceps delivery, birth trauma, mastoid surgery. Functions of the facial nerve: muscles of facial expression, then test from the anterior two-third of the tongue, and parasympathetic supply to the lacrimal and the salivary glands. Okay, so facial nerve exit the skull through the stylomastoid foramina. Again, facial nerve you should read well. So it exits the skull through the stylomastoid foramina. Mastoid process at the birth poorly developed. Risk in neonates: facial nerve injury. Why other options are incorrect? Glossopharyngeal nerve exit via jugular foramina. Vagus nerve also enters via the jugular foramina. Hypoglossal nerve exit via hypoglossal canal, and accessory nerve passes through the jugular foramen. Okay, next. Yes, doctor.
Sir, I can't see the question. I can see now. Okay. During an embryology viva, a trainee is asked about the embryological development of the liver and the biliary apparatus. The liver and biliary system develops as an outgrowth into which of the following embryological structure: dorsal mesogastrium, ventral mesogastrium, neural tube, midgut, mesentery, cloacal membrane. Sir, option B, the septum
Ventral
transverse.
mesogastrium. The liver and the biliary system develops from the hepatic diverticulum, and endodermal outgrowth from the foregut that grows into the ventral mesogastrium. Hepatic diverticulum arises from the ventral foregut, grows into the septum transversum and ventral mesogastrium. Okay, so gives rise to liver, gallbladder, and biliary ducts. So derivatives of ventral mesogastrium are lesser foramina, then falciform ligament, and liver attachment, all from the ventral mesogastrium. Okay, so ventral mesogastrium, liver and lesser omentum association, then dorsal mesogastrium, greater omentum and spleen. Okay, and septum transversum contributes to the diaphragm and liver stroma. Okay, why other options are incorrect? Dorsal mesogastrium forms the greater omentum and the splenic ligaments. Neural tube develops into the central nervous system. Midgut mesentery associated with midgut derivatives, and cloacal membrane contributes to the lower GI and urogenital development. Next.
Yes. During pelvic sidewall dissection, a surgeon identifies the psoas major muscle and reviews the anatomical relation of the lumbar plexus nerve, which nerve passes medial to the psoas major muscle: femoral nerve, obturator nerve, genitofemoral nerve, lateral cutaneous nerve, ilioinguinal nerve. Sir, option B, obturator nerve.
It is the obturator nerve. The obturator nerve L2 to L4 emerges from the medial border of the psoas major muscle and descends into the pelvis towards the obturator canal. So obturator nerve lies on the medial border of the psoas major muscle. Femoral nerve on the lateral border. Okay, lateral femoral cutaneous nerve, again lateral border. Genitofemoral nerve on the anterior surface. Ilioinguinal nerve, lateral border. Okay, so please remember this. The obturator nerve traverses the obturator canal, supplies the medial thigh muscles, may be injured during pelvic lymphadenectomy, obturator node dissection, radical pelvic surgery. Femoral nerve lies lateral to the psoas, then genitofemoral nerve anterior to the psoas, obturator nerve medial to the psoas. Okay, this relationship is commonly asked in the examination. Femoral nerve emerges lateral to the psoas major, genitofemoral nerve lies and on the anterior surface of the psoas. Lateral femoral cutaneous nerve passes lateral to the psoas, and ilioinguinal nerve emerges laterally from the psoas. Next.
During a TAH, the surgeon ligates the uterine vessels close to the cervix. While discussing the venous drainage of the uterus, the left uterine vein primarily drains into which of the following vessels? Inferior vena cava, ovarian vein, internal iliac vein, external iliac vein, common iliac vein. Sir, option C, internal iliac vein.
Yeah, because artery is also coming from internal iliac artery, so the vein will drain to the internal iliac vein. The uterine veins form a venous plexus around the uterus and primarily drain into the internal iliac veins. Uterine venous plexus communicates with the vaginal venous plexus, ovarian venous plexus. Venous drainage pathway is from uterine vein to the internal iliac vein to the common iliac vein and inferior vena cava. So the uterine veins lie close to the ureter, are important during hysterectomy, radical pelvic surgery, and uterine artery ligation. So uterus venous drainage is in the internal iliac vein, right ovarian vein will drain into the inferior vena cava, while left ovarian vein will drain into the left renal vein. Okay. So why other options are incorrect? IVC receives blood indirectly via iliac veins. Then ovarian vein communicates with the uterine plexus but is not a primary drainage. Then external iliac vein mainly drains the lower limb. Common iliac veins receive the blood from internal iliac vein secondarily. Okay. So that finishes the few important questions from the anatomy. Thank you.